said, of course, she doesn't feel that way any longer. And I'll have something to say about that silence in a moment. But I want to play you this little bit of a second clip because Dr. Bisa later clarifies her story a bit. She didn't terminate employment with inpatient and then immediately apply for outpatient. She actually spent a little bit of time at another institution.
I went to Humanities Hospital, and I worked there medical intensive care for 4 or 5 months. And I'll never forget, one night we had a young lady, and she was early teens, not too much younger than I was, who had overdosed with pills, didn't work, then proceeded to try to hang herself, didn't work, then cut her wrist. And I remember as we performed CPR on her, resuscitated her, they assigned me to her. I remember thinking, oh my God, you just attempted to do everything you possibly could to end your life. And I've come from a place where people were doing everything they possibly could to save their life. And that was the moment I made the decision. I'm going back. That's who I am. That's what I want to be.
I really, really like this story, first of all, because it shows that journey of discovering professional values and making really, really important career decisions on the basis of those, that what's going on inside you. Where is your ethics? Where is your sense of purpose and vocation? The other reason I like this story is because it shows the double edge of oncology. You do work with people in this profound period of trauma and crisis, and that can be very draining and challenging, and you have to know your own limits and find the way you can contribute if that is indeed the field you want to be part of. But on the other hand, it gives you enormous rewards. So keep that in mind, and that important issue of the silence in the story, which is basically at this time a profound failure of the institution to recognize legitimate emotions that providers have. I mean, a number of presenters already have talked about that tension between the intellect and the emotions. And unfortunately, the reality in healthcare institutions today is there is very little structural support for expression of those emotions and to reward them and what they can mean to an institution. And part of my motive and mission as a collector of such stories is to preserve them, but also help institutions leverage these stories for their own benefit. And we'll talk a little bit about that later on. But now I want to do just a little bit of background about the doctor-patient bond before we turn to more stories. And historians of medicine point out that any concept of the doctor-patient bond in any culture is very historically situated and culturally situated. And today we find ourselves in a very interesting period where two currents kind of come together to create this Janus-based set of options, if you will, for what a physician or what a provider might look like. On the one hand, modern medicine, as Dr. Buckwell talked about a little bit earlier, modern medicine was born when physicians began to think of themselves as scientists. And in fact, the wearing of the lab coat came about at the end of the 19th century when doctors wanted to make that visual separation, because before they wore street clothes, but suddenly they began to wear the lab coat as a way of discriminating themselves from other providers in a hospital setting. We are the scientists. We have connection to a laboratory. And that created a kind of persona. We're empirical, we're objective. And what's the place of emotions in all that? What do we do with that? Let's keep a professional distance. Let's keep professional objectivity. There's a couple of really important memoirs you guys should be aware of right now. One of them was published earlier this year by Abraham Nussbaum, a psychiatrist and author. It's called The Finest Traditions of My Calling. Wonderful book. He's a very good writer. And he talks about how contemporary medical education trains doctors to see patients as, quote, parts and money. And he's referring with the parts idea to the notion that physicians really don't relate to a patient as a whole person. They're taught to relate to not only the human machine, but the specific part of the human machine that is their specialty. And he talks about medicine being broken because of that fact. Now, the other option for a physician is to be really the caregiver. And the contemporary model for this is the patient-centered care that Dr. Barron talked about a little bit earlier, where we focus on the patient as a kind of partner in creating his or her narrative of treatment. There should be rapport, there should be a relationship of trust, so that the patient can open up his or her world to the physician or to the provider, and so that they can really relate to one another as human beings. So it's a very, very deep kind of relationship. Historians point out that the model for this actually started also in the late 19th century and came not from medical schools, but from psychotherapy, where you have that deep bond between the therapist and the patient who is revealing his or her world in as complete a way as possible. Now, the next story I'd like to share with you really follows up with a wonderful statement about the MD as caregiver model. This is Norman Jaffe, who was head of pediatrics at MD Anderson for many, many years. And who is the person who's helping me with audio, just in case we have a problem here?
I do go to synagogue every week, and my wife runs a kosher home with our children and such. So we believe very deeply in our faith. In fact, I will tell you something. I lost a child at the age of 12. I was advised to take her to the Mayo Clinic and during an operation was performed, and she died 2 days later. So I know how people feel when they lose a child. And I'll tell you something, no matter what the psychiatrists and psychologists and everyone else do, if you will overcome the problem, never do. And when I lost a patient, I know how my parents feel. But I'll tell you this much, that I have insisted while I was in practice, that any patient of mine who dies, be it even in the middle of the night, I must be summoned to that patient's bedside. And I've risen from my bed in the middle of the night, at 3 o'clock in the morning, to speak to the hospital for a dead child, so that I can sit and talk to the patients and comfort them and tell them that above all, everything that could be done was done for their child. That they must not feel in any way guilty or have any other feelings about that situation. And this is not only because of my own personal loss. I think my religious experiences has stimulated me and induced me to do that as well. But I'll tell you this much, some of the greatest relationships that I have had and still continue to have is the friendship and the support I have from the parents of deceased patients. They write to me every year, come to Houston to see me every year. When I retired, I would say about 20% of participants in the retirement party were parents who flew in from various parts of the country to thank me for what I had done. I really felt embarrassed about the situation. They came from Boston, they came from Los Angeles, Ohio. Those friendships, money cannot buy, and they will be with me forever.
I really love the way this clip talks about the way that human bond endures across space, across time, inspired these parents and patients to come to a retirement party to a physician, for a physician who had helped their child, even though the child had passed away so many years before. The other part I really like about it is the way that it shows different facets that a physician draws on in creating that bond. I mean, certainly the personal experience, the ability to extend a hand of kindness and compassion that fuels the physician's vocation to draw on his own experience of having lost a child to counsel patients. And when I didn't ask Dr. Jaffe this follow-up question because we went on to other topics, but I wondered, in his desire to reassure parents that they should not feel guilty for what happened to their child, if that had been an emotion that he had suffered from the loss of his own daughter. So the importance of that relationship of one human being opening the heart to another human being is something that really comes through in this clip. Now, of course, the question is, why don't all physicians do this? Because, in fact, not all of them do. And to kind of preface my discussion of this, I'd like to tell you about an informal conversation I had with the head of faculty development not too long ago. This person, Janice, her name is, was called to serve as a coach for a relatively new member of the faculty, a young surgeon, who had been referred to her for various coaching sessions. And coaching sessions, professional coaching sessions, can be pretty deep. You go have pretty in-depth conversations about your experience, your training. And Janice was telling me that this surgeon recounted some of her experiences during her surgery residency. It was talking about her very close relationship with her mentor, and painted this scene where one day she and her mentor were in the operating theater performing surgery, and to make a point, her mentor stabbed her in the hand with a scalpel. And this young faculty member, Janice, was appalled to discover, thought this was entirely normal behavior. And in fact, this young woman had been referred to faculty development because of her coldness and inability to establish relationships with patients. And this kind of goes to that left-hand side of that Janice face figure that I talked about a little bit earlier. There are some real reasons why some doctors don't create that bond with patients. First of all, traditional medical training often focuses more on the body machine. And it is pretty rare that you find medical school programs that do focus on emotional intelligence and relationship building, okay? And also, to date, the selection process has also privileged individuals who are real good in laboratory skills, book learning skills, less so on the people skills, though that is certainly changing. Also, we have the pressures and culture of medical institution. We talked quickly about some of those pressures, but the culture of medical institutions is also a problem. Abraham Nussbaum, in his memoir, talks about, for example, how in residency programs and in internships, students may start out identifying not with their mentors, but with patients, and they find the behavior of physicians appalling, and their rudeness appalling. But there's a pressure to tamp down their emotions, to behave in a brusque way with patients. So there's an acculturation and even a hazing process that takes place to numb physicians as they go through their training to the human dimensions of that bond. Another memoir that's real interesting is Danielle Offrey's book, What Physicians Feel. It came out a couple of years ago, also very, very interesting. Has some pretty incredible stories that she tells. There's also a kind of bit of wisdom, which is really non-wisdom, that if a physician becomes very emotionally involved or expresses too much compassion for patients, that they're going to burn out faster. In fact, that's not the case. In fact, the opposite is true. It's the physicians who maintain that empirical distance who are actually at a greater risk for burnout. There are a number of assumptions as well that physicians can make about patients' emotions, and I'm going to talk about that in a moment because I've got a really great story for you. But let's hear an example of how the bond with a patient can actually be not just a nice thing to do, but a really important part of, in this case, cancer treatment.
Clearly, the problem that our patients are facing can be not only daunting, I mean, it's mind-boggling. Once you're told of a brain tumor, this scare factor is so high that they sometimes are paralyzed. And so it takes this interaction between the patient, the family, and the caregiver to give this regained confidence in dealing with the problem and beginning the fight. I frequently tell them this is a long road, even if I'm operating, doesn't mean you do surgery one day and you're done the next day and that's it. It's over. It's not. You have a long road ahead. And so they need to brace themselves and prepare themselves. And to add to that, the discomfort of a poor interaction or a suboptimal interaction with your caring team, that in no way will help. The contrary is very true. When you have someone that takes time to listen to your problems and that makes you feel that they really understand what's going on in your life as a patient or as a family, the power of that is immeasurable on the eventual outcome. They get added confidence, I think.
I'll just stop there. Now, obviously, it's the right thing to do. Dr. Sawaya talks about how it's also very important for the kind of durability, if you will, and the courage of the cancer patient to have support from the caring team in order to really optimize the treatment process. And one of the things I was really struck with in my interview with Dr. Sawaya is how important his relationship with his father was in him learning about this. His dad was a physician, and in fact, Dr. Sawaya had the great opportunity of accompanying his dad on house calls when he was a young man, a boy even, and then as he was a young man and then a young professional. And so he watched his father interact not only with patients, but also with entire families. And Dr. Sawaya really got that model, is how do you treat the individual as a whole person, and how do you treat that whole one person within the larger organism, if you will, of the family, and even of an entire community. I'm not actually going to play you this clip from Dr. Pollack because I'm running a little short on time here, but I did want to make the point that that apprenticeship model of learning by example, learning by standing by another physician or another provider's side and seeing actually how someone interacts, having that model is still the main way that trainees learn these kinds of subtle emotional and relationship skills, and it's actually not an inappropriate way. This is experiential learning, and it's darn hard to learn that kind of thing out of books. So even if you get a framework for it, you're going to have to put it into practice by being by someone's side and then being face to face with actual patients in a setting. Now, I wanted to go back to that idea that clinicians have a set of assumptions about patients' reactions, because the next example I want to play you capitalizes on that. And I just want you to think about yourself. You know, if you have to give somebody bad news or you tell them something, you have a sense of, well, what's a normal reaction in this situation? Well, physicians have that kind of reaction meter in their brains too. So when they deliver bad news to a patient, they have a sense, well, how upset should this patient be getting? And if that patient gets really upset, much more upset, the physician's tendency can be, or the provider's tendency can be to say, oh, this patient's being weird, or has a problem, or refer them to psychiatry or behavioral sciences. I don't want to deal with it. Okay? That's sort of a normal human reaction that can shut them off to the patient's response. Now here I want to play you an example of how, I'm sorry, I'm so bad at doing these with the, how ignoring this can have an impact on patient outcomes.
So people think, well, it's just the cancer that knocks people from it's blood cancer is on top because they're stuck. It's still dealing with the past. There are many women for whom their cancer is very, very traumatic. And breast cancer, for example. And, some people fly through it. And if you take the time to explore the background of these people, just like you did with me, you find that a significant number of them have histories of abuse, often sexual abuse, or parents who were alcoholic, physical abuse. And so this cancer experience feels to them as if they're back in the victim role when they were children. Very real. And I had one woman say to me, it took me a long time for me to figure out why I was feeling like I felt when I was a young. And that's the beauty of being a psychiatrist, because you're able to help people figure out why they're being troubled by stuff that they can't understand, and to be resilient.
It may have been a little difficult to understand what Dr. Vail was saying there. He was quoting his patient as saying, it took me a long time to understand why I felt like I did when I was 6 years old. Now, the point here, there's a lot of research coming out that these breast cancer patients who did have sexual abuse or some kind of trauma in their younger years are actually at very high, much higher risks for poor outcomes in their cancer treatment. The reason is they go back to that place of victimhood when they were children and powerless. They may become extremely avoidant of bad news. They may be unable to advocate for themselves during the treatment process. They may become very passive and not assertively take on what they need to do. They may miss chemotherapy appointments. They may not pay attention to their diet. They may not go to meditation. They may not take part in the kinds of aspects of their treatment that are going to help them maximize their health and get through this process. This personal history, I'm just going to read here from one of these studies, is a predictor of longer-term secondary effects: depression, anxiety, sleep disorder, poor quality of life, negative affect, cancer-related PTSD, non-participation in the treatment plan. Okay, so it isn't important only for psychiatrists to understand this, but for the primary oncology team. That means that doctor who interviews that patient cannot dismiss overreaction. They need to understand their own assumptions in interpreting how patients are responding emotionally to a situation. Okay, so we've talked about the advantages of the doctor-patient bond for patients. But what about for doctors? And this new field of survivorship actually has revealed something interesting about that. I mean, in the 1930s, the 40s, even into the 50s, cancer was a death sentence. But then treatments were discovered. They improved. And now people are surviving. And in fact, there are some cancers that are being managed now as chronic illnesses rather than as any kind of serious threat. And here, there are two authors, Louis Foxhall and Alma Rodriguez, both at MD Anderson, are two individuals I've interviewed who have been very instrumental in doing research in this emerging field. And think about it. I mean, here's a central question for this new field. When does a patient become a survivor? I mean, when's that point? At what point do you move from being treated by your oncology team and suddenly go back to your general practitioner? That's the question. So in researching this, Dr. Rodriguez found out some interesting things.
We were asking people to, for lack of a better word, divorce themselves from their oncologists. So the reason that the so-called model of the doctor-patient relationship has lasted for such a long time is that that is very inherently basic to human psychology, the healer-healed person relationship. We talked about extensively in psychiatry and psychology, and it's real. Particularly in a situation where the patient perceives that their lives have been saved by this individual. And so it can be very emotional, it can be difficult, both for the patient and the physician. We found that in some cases, it wasn't necessarily so difficult for the patient, but in fact it was more traumatic for the physicians because they felt that seeing these patients who are well, who had survived the cancer and were still free of the cancer, that was the height of their day, that was the most enjoyable part of their day, and we were going to deprive them of that. So that was the challenge, the psychological separation.
I mean, that goes to the heart of vocation. You know, how do I know I'm a good doctor? How do I know I've had an impact? How do I know I've had a success? I mean, very, very important and an essential part of what drives the physician, not only to continue to practice in a stressful field or just practice in general in a stressful environment, but also to continue to give to the institution in which he or she practices. Now, the last story I want to play for you is another instance of meaning creation, but one that's really comes from the unique situation at MD Anderson. And I've actually denied Dr. Pollack part of his title. He not only has an MD, but he also has a Ph.D., which he earned after he started working at MD Anderson. He's a physician scientist, which means he does clinical work, but also is very active with clinical research. And he got his Ph.D. because he realized he needed to do that higher work in order to create strong methodologies. And here he's telling a story about work with a patient who has metastasis, a metastasis for which there is no treatment.
I had patients who had metastatic liposarcoma. The disease was indolent but progressive. This individual came to me and said, I'm looking for something to do. Could I be a volunteer at the lab? So we were able to work that out. And because of his administrative acumen, he was able to totally reorganize our tissue repository, put it in a barcode system, and set up a whole tissue procurement network. And for the last 4 years of his life, worked as a volunteer in the lab and became very closely integrated, came to our Chinese New Year's parties. And it was very, very meaningful to everyone, knowing that this was someone who was going to die of the disease that they were studying. He had a number of operations performed by me during the time that he was in the lab. So tissues were used in a very direct fashion. I think the value of this is bringing home the message that whether you're in research or clinical care, if you work here, it's ultimately about people trying to help take care of other people. It was a very, very meaningful relationship for all of us. The entire lab was invited and went to his funeral. Very meaningful.
I mean, there's so much that we could talk about with that story. It's amazing. But a couple of things I just wanted to mention. How, you know, not only was there a doctor, an MD, and a PhD bond, but this was a situation in which the patient was given amazing agency in the context of disease and treatment. You know, the person knew they were going to die of their illness, but they nonetheless had a sense of mastery, that they were doing something very active to help other people who would have this same illness. And also, of course, the fact that it was a very unique situation in which not only clinicians, but in which basic scientists could have a relationship with the patients whose work they has an impact on. That people who were in the lab would never ever see patients, had an opportunity to work with a representative of the disease that they were working so hard to cure. So a very, very important example of how meaning can be created with a doctor-patient bond.
I had patients who had
Sorry
medicine.
about that. So, some final thoughts. I had a conversation a couple of weeks ago with a faculty member at MD Anderson who every once in a while puts together little discussion sessions so that providers, MDs, and also other providers within the institution can get together and talk about compassionate care and its challenges. And I thought, wow, you know, hey, does this happen all the time? I'd really love to come and be part of this. And he goes, well, you know, it really only happens once in a while. I did this because there was an author coming to talk about his book on the subject. And I go, you know, really, why? And he said, well, you know, people find it really challenging. And I thought, okay, there's a story here. And he said, yeah. And here's what he said. The question they had was, once we share our deep feelings, how do we go on to relate to one another as professionals? And I just thought, what an unbelievably sad question. And it goes to the heart of one of the problems in institutions. And really, as people in the humanities, people who are going to be leaders in this field, you need to think not only about the micro level, you as practitioners in this field, as future practitioners, but how are you going to have an impact on the entire institutions in which you operate? Institutions in this country, not just medical, are ill because they do not know how to deal effectively with individuals' emotional lives, how to deal with unpleasant news, how to deal with conflict, even how to deal effectively with joy, because this is what a lot of these people are talking about. They're talking about joy, they're talking about passion, they're talking about spirituality and a very deep feeling that fuels what they do, keeps them coming back to do work that is very hard work. I don't know if you guys know, but retention in medicine is very, very hard. Physicians are leaving the field, and where it used to be that there were multiple generations of doctors in a family, doctors now are telling their kids, don't go into this, it ain't worth it. And also, UMA, this is a depressing statistic. Every year in this country, almost 400 physicians commit suicide. That's the loss of one medical school class every year. This is sad. And part of it is that the value that people do get from practicing their art of medicine is not recognized and not rewarded properly by institutions. And this is a very, very dangerous fact, not only for individuals, but also for fields. I mean, I have these little flowers growing in the cracks. I mean, we got to see an upside here, okay? So how do we harness the energy? And what can happen if we do harness the energy that is expressed in some of these stories? Well, first of all, for an individual, if we suppress the stories, it can mean a horrible lack of support, like Winona Easton, okay? A lack of support for individuals at critical moments in their professional career, and a lack of a sounding board so that they can help them go through that reflective process that Dr. Rockwell talked about. How do I process this moment in my career and learn to grow from it quickly and effectively so I can become a more sophisticated and more effective practitioner? For a community or team of professionals, it's incredibly important. People can bond around these feelings. They can become more effective. They can support each other. They can serve as sounding boards when there are those ethical dilemmas, which I'll tell you are much easier to read about in books than they are to confront in the workplace. And I see your nods going back. Yes, some of the situations that arise, they did not think about when they wrote those textbooks. So you need people around you to help you negotiate those stormy seas. So if you can share this kind of thing with your team, then you've got a family that you can call on during those moments. For an institution, if we lose this emotion and lose these stories, it means a huge loss of an amazing resource. I mean, leaders talk now about engagement. You know, what is it about an institution that inspires an individual to give that extra 20% of time and energy, to commit loyalty and time and energy to the institution? It's when there's a link between the values of an institution and the individual's values. And if the institution supports the vocation of its practitioners, it will get that engagement. That means that institution is going to be better at doing everything and stronger in the marketplace. And of course, for the field of medicine and biomedicine and research, it's incredibly important. As technology and big data take over, medicine is becoming in danger of being very dehumanized, and we have to be very, very assertive methods taken to make sure that that human dimension does come back in. So if we lose our deep stories of deep purpose and lose our attachment to this kind of emotion, we are really lost. So this is my message from these stories. It's really very, very important, and I would charge you all to find ways to help integrate this into medical life. So I want to thank you for your attention, and I'm very, very happy to take questions and comments.
I have a comment. I wanted to just draw out from you the idea of the creativity and